A very warm welcome to all of you to this special session on social work and HIV/AIDS. In this particular session, we shall be talking about HIV/AIDS in relation to stigma, and we have with us Professor Neil Abel from the University of Florida. The topic he would be dealing with is addressing HIV/AIDS provider, stigma, awareness, acceptance and action in healthcare and social services. Professor Neil Abel, he had been to several cities, particularly in the north, in the state of UP and Punjab. He has also visited a couple of schools of social work, has interacted with the school teachers as well as people working in the area of HIV/AIDS. He is a clinical social worker, has developed several measures to educate people on the prevention and control of HIV/AIDS. He is an internationally known person, has worked very much in the countries like Vietnam, in UK, in the West Indies, and no doubt across the United States. We are very pleased to have him with us here. He would be making a presentation of about 30 minutes. Now I request Dr. Neil Abel to make his presentation. Dr. Neil.
Thank you. I'm very grateful for this opportunity to talk with people from a great distance about the issues of HIV/AIDS, and my colleagues would insist that I say that I'm from Florida State University, not the University of Florida, because we have some competition with them. As I talk about the issue of AIDS provider stigma, I want to start with a premise that was introduced to me by one of my teachers, who said, when conditions are sufficient, something will arise. And the significance of this statement is that as we look throughout this conversation to the context in which HIV/AIDS has become so large a factor here in India and in other parts of the world, we have the opportunity to look at our own experience as individuals, at the experiences of our families, at the experiences of our culture and even society, to ask what circumstances have come to be such that the virus now presents itself in the way that we currently observe. So I want to talk about the transition of a problem moving from an epidemic to a pandemic. And when we consider the broad sweep of HIV, it's very important to be aware that it has impacted not only those persons who are directly infected, but also all of those persons who are affected. In other words, their family, their caregivers, those who work with them and are otherwise economically involved in their communities. All of these people are affected by HIV, and consequently, these issues are of concern to them as well. Peter Piot, who is the executive director of the UNAIDS organization, made a very clear and important statement in 2003 when he observed that AIDS had killed 3 million people in that year, and that was an increase of 2.8 million from the year before. As he observed, it continues to kill more people. It continues to infect more people. And in 2003, he said we are now with 42 million people living with HIV/AIDS worldwide. His themes were correct, even if his exact numbers are now slightly modified as we move into 2004. We see now an estimate of only a little under 40 million people, which is still a drastically large statistic. But these numbers have come down partly because deaths attributed to HIV have increased. So we see that the illness is moving forward and at a very alarming pace. In India, the most recent statistics suggest that we are currently facing over 5 million people infected with HIV. And these infections together constitute nearly 1% of all persons between the ages of 15 and 49 years of age. So for these people, we see that there is a huge need, and according to most indicators, that need will only increase in the foreseeable future. It is, however, concentrated at the moment primarily in the South and in the Northeast. My opportunities to travel during this recent tour throughout provinces in the North have indicated to me, based on the reports that others have provided anecdotally and more broadly from their regions, that there is both reason to be concerned that the impact of HIV is spreading into the North, and also reason to be encouraged that a great many talented and dedicated people are involved in mounting their response. So one of the first important issues to consider are the most basic issues, and these involve the nature of HIV and the extent to which it is difficult or easy to avoid acquiring the virus. And when I say that it is relatively easy to avoid getting this virus, the word "if" in my PowerPoint is critical, and it encompasses factors that range from the individual all the way to the societal. And so we should note, first of all, that in order to avoid getting the virus, people need to be educated. They need to have awareness about the factual information regarding which bodily fluids transmit the virus, primarily blood, semen, vaginal secretions, and breast milk. And they need to be aware also of the myths that surround the virus. For instance, that it can be transmitted by coughing or sneezing, by handshakes, by hugging, by sharing a meal with a person with HIV. To the extent that we allow these myths to perpetuate, we continue an atmosphere of ignorance and perpetuate an environment of fear that is avoidable if we have the opportunity to let the education penetrate. After being educated, persons need to have access to barriers. And those barriers may include, for example, a clean blood supply, where we need not fear the transmission of the virus through transfusion. They may include access to formula so that an HIV-positive woman who is raising an infant need not breastfeed that child, but can give nutrition in another alternate manner. And also we need access to condoms for people who are sexually involved and who may wish to minimize their risk through sexuality. When those barriers are in place, then we need the power to control our lives. And this is where issues ranging from the most personal and intimate to the broadest and most socially prevalent all come into play. We know that gender dynamics play a huge role in the power that persons have to say yes or no to sexual relationships. And in that power lies the ability to protect oneself successfully from HIV. And finally, we have to have the will to engage in these ways. And while this may be very personal, for instance, when someone is depressed, when someone is intoxicated through the use of alcohol or injection drugs, and we find that their will may falter, it may also be very large and societal. When we see that persons in poverty, persons who are trapped in a cycle of despair and deprivation, may, because of influences much larger than their individual lives, lack the will to exert this control at all times. In India, we know that most infections occur through sexual transmission, although there is a growing proportion associated with injection drug use. And I have to also indicate that when we see descriptions of the routes through which the virus is acquired, we should remember that the best information we have to guide us in this area is the self-report of the persons who have allowed themselves to be tested. Consequently, in terms of awareness, we have to cultivate atmospheres in testing and treatment centers that are conducive to trust for persons who have been at risk for HIV in order that the information they provide us can be most helpful. The second large question is, do we have to die? And in this regard, we need to remember that there is, as of yet, no cure, and also we have no vaccination that will prevent the acquisition of the virus. Medical science continues to advance, however, with respect to treatment for HIV. And so, once again, in one regard, we have great reason for hope. However, for HIV to be a treatable chronic disease, there are a number of ifs which also must be addressed. First of all, clearly the person in need must have access both to medication and care. And there are many efforts nationally and internationally now to increase the access to HIV medications within India. It's come to my awareness that in some instances the drugs may be available in some communities, but that availability is not known to all of the persons who might benefit from understanding it. So we need to have access to medication and care. We also need to have informed expert services. Doctors and nurses and social workers need to be very up to date and current with respect not only to the medications which are appropriate, but to the ways in which they must be taken in order for the patient to fully benefit. So we need to meet the broad needs of a person who is taking medication and make sure that they have the willingness and the ability to monitor their use of the medication at all times. And I feel that this is an avenue for lifelong support as provided by social workers and provided by physicians in healthcare settings. One common statistic is that when the medications for HIV, antiretroviral medications, are taken as directed 70% of the time, when they are overlooked or forgotten only 30% of the time, the patient will lose 95% of the benefit of those medications. And when we lose this much benefit, consequences arise not only for the patient who is now more susceptible to illness, but also for the public health of the community, because new strains of the virus may arise and be transmitted by this person, which are then resistant to treatment in whoever is affected by the new strain. The Universal Declaration of Human Rights in 1948 emphasized that all persons across the planet had certain minimum rights, certain minimum conditions to which they were entitled, simply by virtue of being part of the human family. And it's very telling for those of us who feel impatient for social change that it took until 1948. It took thousands of years of human history, great trials, great suffering, many plagues, many famines, many wars. All of these things accumulated in the human experience before we were ready as a world community to join together and say, there is a minimum which we will agree to respect. Our awareness as a community developed quite slowly. So while we may be frightened by the urgency of the pandemic of HIV, unfortunately we have to be patient with the amount of time that it may take for these promises, these policies, to be translated into social action, which will benefit the many and not only the few. When persons living with HIV/AIDS seek medical care, they may find that there are a number of factors that keep them away from these services. And those include having too few doctors or clinics or opportunities to receive this care in general, but also the ongoing stigma and fear which provide a background and context for HIV and for the delivery of services. If we fear that learning our status will not benefit us because we will then be at risk of being singled out within our communities for isolation or discrimination, or if we fear that we will be more prone to despair because we're unable to access medication once we know our status, we may have motivations to deny the knowledge of our HIV condition and avoid taking advantage of services. People may fear becoming a burden to their family if they know their status, and fear that others in their families will also be stigmatized as a result of their association with the person who has HIV. Without protections in the workplace, employers may find excuses to release the person from their job, and this can have a cascading effect on the ways in which they meet their basic survival needs. And as I've alluded to earlier, illness management becomes a critical factor when we consider the great price that a person may pay for failing to take the medication exactly as it is prescribed. In Barbados, when I had the opportunity to work with a group of coaches who were working with young athletes and who had been identified as good candidates to become resources for people, young people, learning about their HIV status and keeping themselves healthy and well. At one point in our work together, a certain degree of anger and frustration broke through in our dialogue, and a member of the group asked in an angry voice, "What do the AIDS people want?" And fortunately, in further discussion, the group members themselves came to the conclusion that people with HIV/AIDS want the exact same thing that anyone else in the human family desires: love, opportunities for employment, a chance to be useful and contributing members to their families and societies. Providing this atmosphere becomes an opportunity and an obligation for social workers. And the twin factors of stigma and discrimination become central barriers in dealing with these concerns. When we talk about the extent to which people feel that they have been set apart, labeled, identified as lacking in dignity or worth, we are observing the impact of stigma. And when we see that those attitudes and judgments are translated into behaviors, barring someone from attending school, refusing them access to treatment in a medical setting, or putting their employment at risk, then we are seeing the behaviors which represent a form of discrimination. And when I talk about provider stigma, awareness means that those of us who want to be in professional service roles, social workers, physicians, nurses, etc., we need to be aware not only of the words which come from our mouths and of the formal positions that we take based on our good intentions, but also of the expressions that we give to people non-verbally, so that they may, for example, perceive, not on the basis of what we say, but on the basis of how we look at them, how we gaze at them, that we are judging them, and therefore that we constitute an unsafe atmosphere for them to turn to in terms of having their needs met. And these communications of shame and distance are concerns that people with HIV are highly sensitized to. So as we notice our tendencies to distance from these people, or to avoid them, or to speak harshly about them, we're becoming more aware of the individual expressions of stigma. Institutionally, we may see that on an organizational level, providers may choose in clinics, in hospitals, to separate HIV patients from other patients or to treat them differently. And this treatment can be motivated by fear, it can be motivated by ignorance. Whatever the motivation, when we see tendencies to quarantine or to require mandatory testing or to reveal someone's HIV status, I ask us to become aware of the impact of these decisions on the larger atmosphere of public health. We may believe that we are protecting ourselves in the short run from an identified source of infection, but in so doing, we are sending a message to the unidentified sources, all of the people with HIV who have not revealed themselves, whose status is not known, and we are giving them a motivation to stay in hiding. So we find, for example, that providers may take unnecessary precautions in the delivery of care. They may wish to transfer patients away from their own practice to the practice of another. They may not provide women with prenatal care or with assistance in delivery and childbirth, instead telling them to go away or even to get rid of their baby. All of these approaches are unnecessary medically. Through the use of universal precautions, we have the knowledge and the capacity to protect ourselves from acquiring the virus through the delivery of standard care. So we know that attitudinally, we have to devote our attention to awareness, acceptance, and action if we wish to improve the atmosphere in which services are offered. Developing awareness is based on principles of mindfulness, which include two fundamental goals, and those are looking deeply and listening well. Looking deeply begins with the experience of the practitioner individually. I worked with the Director General of the Red Cross in Grenada and listened to him very bravely tell a group of his colleagues that he had become aware of his own underlying fear when he caught himself while visiting patients in an AIDS ward, having stuffed both of his hands into his pockets. And in doing so, he was communicating to them that he felt unsafe touching them or being directly exposed. Even as a leader at the highest level in his community, he had the capacity to forget temporarily and to unconsciously slip into this behavior. So we have to look deeply, not only at the surface of our own tendencies, and come to understand the roots of these difficult issues. When I said at the beginning, when conditions are sufficient, something will arise. This illustration shows that in this brave individual, still there existed a condition of fear on some deeper level, and that presented itself, it arose in the form of his behavior, even though he wished to avoid that risk. So engaging with persons with HIV requires the cultivation of compassion. And compassion is more than tolerance. Tolerance means I'm willing to get along and go along. I'm willing to share space, perhaps, but don't ask me to get too close. It's a good first step. Sympathy involves having the root of compassion in that we now care for the suffering of another. But it also distances us to a certain extent and implies that we are looking down on them from some elevated position. Empathy moves even further forward in that it allows us to genuinely feel the experience of another and to have a true sense of caring for their circumstances and their suffering. But only compassion motivates us to drop all pretense that we are in some way different from the person who is suffering. Again, when we ask, what do the AIDS people want? If we look into our own hearts, into our own lives, into our own communities, we will see that they, because they are just like us, want the very same things that we want. Acceptance, or the breaking down of denial, means that we move from awareness to acknowledging that it really is up to us as individuals, as universities, as professional bodies, as organizations, to take responsibility not only for responding to HIV/AIDS in specific, but also for addressing the broader social, economic, and political conditions which make it possible for the pandemic to arise. As social workers, we can be advocates, we can take on these issues directly, and we have that opportunity to recognize that in practicing acceptance, we are engaging on all of these levels simultaneously. And this means that when we attempt to work for the improved understanding of people on organizational levels, be they spiritual leaders or business leaders, that we appreciate that they too must overcome the same issues we overcome as we face these issues together. Taking action means then that we move from these concerns to intentionally choosing the way to behave, rather than reacting on the basis of our first impulses or our unconscious fears of death, judgments about sexuality, concerns that we also will be associated with the gutter, as they refer to it in the West Indies, if we come too close to people with HIV. I had the opportunity in working with an HIV-positive nurse in Trinidad and Tobago to learn from her courage. As a person at great risk, she chose to put on a mask in the hospital and to directly provide care for a TB patient, even though the other nurses on the ward were unwilling to do so. And because she could feel the need and the suffering of this patient, as the person at most risk on that professional staff, she chose to practice universal precautions and demonstrate that it is indeed possible to act intentionally and to avoid reactions that are driven irrationally by fear. Her modeling was critical and helped us to embrace the goals of INP Plus to include all persons in such a way that we avoid denial and silence in our response to HIV. Denial contributes only to delay. And even though I have encouraged us to have patience as we move forward, given how long it has taken us as a community of humans to develop a basic foundation for human rights, we have no time to waste in doing our own work and the work within our organizations to make the necessary progress possible. And finally, I would like to say that in the image you may see in this final slide, as we look at the eye at the center of this graphic, we see the necessity of keeping our eyes open as we confront the issue of HIV, so that we may not only see the truth about our own fears, our own experiences, but so that we can see the realities that we encounter socially, organizationally, politically, institutionally, and not turn our gaze away simply because the challenges are overwhelming. And if we can keep our gaze open, that awareness will help us to accept the reality of suffering in an atmosphere not only of compassion, but as is indicated by the heart, which contains all of these elements together, in an atmosphere of hopefulness and experience, that as we move forward together with awareness, acceptance, and action, we can revitalize the response to HIV, bring new hope to the lives of persons suffering with this illness, and work together to prevent its spread in the near future.
Thank you, Dr. Neil Abel, for your excellent presentation. Your topic on expressing HIV/AIDS prevention stigma, awareness, acceptance, and action in healthcare and social service. You have covered every aspect that you have spelled out in your title of this particular presentation. I think he deserves our appreciation and a clap.